Hey, Dinks. We are live. It's Wednesday. It's Hump Day Happy Hour, and we are so excited to have you with us tonight. We have a great guest and a phenomenal educational partner with Align. Big announcement today. They just announced their new scanner, so we're really excited to maybe talk a little bit about that and where we're headed in scanning technology, because I think it's ever evolving. So hopefully you had a great Wednesday. As you can see, I'm all alone. Chad is under the weather and Jeff is having some technical difficulties. It's never, a complete Wednesday if we don't have a little bit of shenanigans before we go live and stress and sweat about whether our mics and cameras are working for that day. Jeff did get a new computer recently. So, I always feel like anytime we bring on new devices, and I've recently experienced this with my new studio, that it never seems to be quite as smooth as it was when you had all your old operational things in place. So who knows? Hopefully he'll get it worked out on his end and we'll be able to get him on here live, because quite frankly, his intros are way better than mine, if we're all being really honest. So hopefully everybody had a great Wednesday and actually a good start to the week. I'm actually heading out tomorrow. I'm leaving for Aruba. I'm heading to the Clinician's Choice Conference in Aruba with some of our phenomenal guests that have been on the show before. Diana Tadros, Amanda C. Adamo is going to be down there, who we really wish could be on the show tonight instead of Chad or Jeff. Anyway, it's going to be a fun time with a really great clinical group, and always enjoy my time with colleagues, with previous guests on the show, and a really great restorative company. So hopefully we'll have really good weather and I can get out of this cold, gloomy North Carolina day. Tonight we have a phenomenal program. As I mentioned, we have Align as our educational partner, bringing our guests to us. We have Dr. Baird here, who will be joining us from the West Coast. So she just finished up her clinic day. She's an orthodontist, so she's going to talk to us a little bit more about clear aligner therapy and what that means for her practice. So we're really excited to have her on. Can it be? Is Jeff coming in? Is it true? Anyway.
Can you hear me?
I can hear you.
Okay, so we've got audio, but no video. So has this ever happened to you? By the way, beautiful intro, JP.
Well, it's not as good as yours.
Well, thank you. My news is not as good as yours. So
Okay,
anyway.
thanks. I appreciate that. All right, Jeff, is it okay if I do the news?
Please go ahead and do the news, and I am going to keep messing with my computer while you do that.
Okay, sounds good. I'm going to drop you down while you keep figuring out your life. All right, team, we've got some big news for you this week, so we'll try to get straight to it. First off, so this topic came up actually in discussion when I was at the AGD's Joint Council meeting, and we were talking a lot about dental loss ratio. And there is a fair amount of states that have legislation coming up in the next calendar year, just like Massachusetts had in November of last year. And if you don't recall, that was the question 2, where they passed an 83% medical loss ratio for dental claims. What that means is that 83% of the income generated by the insurance company should be allocated towards direct patient care. And that could be marketing initiatives. It could be payment increases to providers. It could be allocation towards dental benefit. So that was passed in Massachusetts. It created kind of this swelling up of activity in the U.S. to look at passing similar legislation in other states. So there are quite a few that have it up for vote this year. Well, interestingly enough, the American Dental Association and NADP, which is the National Association of Dental Plans. Yes, many of the dental plans that you take in your office that you are in network with are members of NADP. It is the collective organization that represents a good number of dental plan providers in the U.S. They got together last week and came up with an agreed upon model legislation mediated by NCOIL. Yes, another acronym we're going to bring to you tonight. That is the National Coalition of Insurance Legislators. How do you like that? They mostly operate on a state level, but certainly have some involvement on the federal level. They are constantly looking at legislation and how it impacts all insurance providers, not just dental, but medical, life insurance, disability, all gamuts of insurance. So now we're getting you totally in the weeds on this whole dynamic world of insurance. So the ADA and NADP got together last week and came up with an agreed upon language for model legislation for those states and for future states that are looking at dental loss ratio. They're also rephrasing it, dental loss ratio, as opposed to medical loss ratio, to differentiate it from medical insurance. So dental loss ratio model legislation has been published. There's been a whole uproar, not all positive, about what that legislation may look like. I can tell you it won't look much like Massachusetts at 83%. I think it'll be closer to a middle range, somewhere in the 60 to 70%. And it gives a lot of power to the state commissioners to be sort of moderating these dental plans state by state to make sure they're all staying within these certain parameters. And for those who are not complying with the appropriate guidelines or seem to be outliers from what other plans are doing, they will be remediated and potentially asked to no longer provide plans in the state. So that's where we are with dental loss ratio. That's where the model legislation is. I expect to see some of these states look at that model legislation and sort of recraft whatever bill they're proposing to be voted on coming in November. And we certainly have a lot of big players at the table with the ADA, NADP, and NCOIL all involved in coming up with what ultimately will be the final legislative, I think probably will be what model legislation will look like moving forward. So this is an interesting development, certainly on the heels of what happened in Massachusetts of last year. And so we're continuing to sort of watch that and see what really comes of it. Another interesting development this week, and it doesn't seem new to me, but maybe it's new to the general population, or maybe the technology is continuing to get better. But there actually was a lot of activity just in the general news media with dentistry and brush biopsy. We've seen brush biopsy be available to dental providers for quite some time, but it seems like there's an uptick in enthusiasm and marketing for the brush biopsy so that providers can start to do pre-screening or early screening for oral cancers. I think the technology is continuing to get better so that we can at least start to determine malignant versus non-malignant with a brush biopsy. Of course, then a biopsy would certainly be further indicated for an official diagnosis, but it looks like brush biopsy techniques might be getting more sophisticated in how they're determining whether or not we have a cellular change on an mRNA level, and then whether or not we need to then move forward with a biopsy. That could be really exciting news for providers who want to be able to do early screening and detection for patients, but are not either eager to pick up a scalpel or a punch biopsy, or have some challenges with getting patients referred to the appropriate parties for a official biopsy. So maybe this will be a nice welcome addition to our already very stringent oral cancer screens and examinations that we're providing in our practices on a daily basis. The last piece of interesting news for the week, we're going to see Wisconsin take up new legislation, it looks like by the end of this month, which could be today, to approve a dental aid therapist into their breakdown of individual dental providers within the state. This certainly did open up their Dental Practice Act. So there were a few other items that they were able to change in their Dental Practice Act as well. But most notable, and I think worth mentioning, is that we're now going to see a dental health aid therapist available to be licensed in Wisconsin. There's certainly a lot of discussion around the idea of a dental health aid therapist and could be quite contentious between parties. The biggest issue that I have seen so far is the actual number of programs to educate and license dental health aid therapists doesn't quite meet the need of what these states are asking for. We don't actually have the programming and educational support for these dental health aid therapists to be providing care in the communities. And remember, these DHATs are able to do fillings, extractions, and other what they would determine as easier procedures within the clinical practice. That's always been a little laughable to me because I've definitely opened class 2s before that I thought were going to be easy and kicked my rear end all the way home. So kudos to them if they can discern which ones those are going to be from the get-go. But we're seeing an uptick in states that's now number 10 or 11, I believe, with dental health aid therapists as a licensed provider in their state. And we haven't quite seen the uptick of education to match the need. And with that, that's the news.
The news was great as always.
Thanks.
I think the topic, the topic of, this mid-level provider thing, there's so many ways that this can go. I mean, we're already short on, we're already really short on hygienists. Why not expand the duty of people who already have that kind of an education, or extend the education a little bit? I just think that there's a lot of ways that we could go with this, and maybe bringing in, one more classification is not necessarily what we need.
Boy, it sure does make the water a little muddy when you're dealing with dentists that are over in debt on education, hygienists that are absent in the marketplace, and then you add a mid-level provider. I really don't know how all this shakes out, what this is going to look like 10 years from now.
I don't either.
Yeah.
And I get I don't want to deny anyone the access to care. This is not about me protecting the pocketbook or just dentists in general, because, we want to pay hygienists to do that job.
Right.
I mean, we don't always want to be in doing, 4 class 2 fillings if we're too busy and can't find an associate, to fill that position. So, but I think there's room. I mean, I don't know, why do we always need another entity? I think we don't really utilize our teams as well as we could. And I think that's where the room is to maybe allow some of these people who have more passion within the practice to advance their degree to some level.
I do love the opportunity to take the people we have and keep growing them.
Right.
Because that is the hard part of any of our staff, is that they cap out at some point in what they legally are allowed to do without actually having to leave the profession temporarily to go get education.
That's right.
And many of them don't have a circumstance, or moms, fathers, whatever. They don't have a circumstance in which they can just not earn an income and go back to school. So I love lifting up from within. I wish we had more opportunity to do so, for sure.
And quite honestly, what somebody learns during apprenticeship or mentorship can be way more valuable than what they could leave a job for, go get new education that, turns everything they've already learned about the profession upside down. So
For sure.
I think we really need to have a roundtable one night just on this topic, and because I think that there's so many directions, and maybe that's something we share with the ADA or the AGD, and because I just think we're, excuse my French, we're just throwing shit at the wall. That's all we're doing.
We'll see what sticks. Yeah.
All right. Well, why don't you introduce our guest, JB, since you've done everything else tonight?
Why don't I just keep doing the heavy lifting for everyone? And while I do that, would it be okay if I bring her up so we can see her?
I was going to do that part.
No, I don't want you to lift a finger tonight, Jeff. You just be pretty, sit there.
My fingers have been working to the bone trying to figure this out.
I bet so. I can only imagine what it looked like with your little readers on, like trying to figure it all out.
Thank you.
You're welcome.
Hi, Marta. I'd rather talk to you.
Hi, how are you today?
I'm good. It's nice to meet you.
Pleasure to be here.
Well, welcome. First off, thanks so much for joining us tonight. Thank you to Align for giving us the opportunity to have you on here. Maybe we can talk a little bit about the scanner that was just announced today. That could be kind of exciting.
Yeah.
But as we mentioned in the intro, you are an orthodontist practicing in California. You're an Align faculty. You've been with Align for quite some time, pretty passionate about clear aligners in your practice. Can't wait to dive into that a bit more and hear a lot about your journey. So welcome.
Thank you.
Oh, golf clap. All right. So without further ado, let's talk about your journey. What got you into dentistry? What are you from? Where you practice? Are you in your hometown? Tell us a little bit about you.
And any relation to Bruce Baird?
No, Baird is my married name. So
Okay.
I started out as a parasec. So parents immigrated here. Mom was a dentist, did her international dental training here, and I saw how hard she worked, and I thought,
Yeah.
well, that seems like a really noble profession. And so she's the one that really steered me into specializing. So I'm a dentist, first orthodontist, second, and then my brother was a dentist. So it was one of those things in the family.
Oh, cool.
But there was always a backup plan, right? Because I did the 2+3 program, which they have where you're performing root canals at age 21, right? You're in dental school. You don't really know if this is going to be something you're passionate about, but I got really lucky. So got into orthodontics and found out it's something that I really enjoy. And I really enjoy technology. So that's sort of it really has what has brought my because I'm 10 years out of graduation since residency, and where I am today, I would not have foreseen that when I was a graduate. The way that technology is changing our specialty, the things that we're able to do, that's what keeps me excited to keep learning and keep engaging. Um, so yeah, that's my story. I never really left the Bay Area of California though. Right? UOP is in
Yeah.
Stockton. We've got the SF campus. My parents are 30 minutes away. I'm
So here's her
as
problem.
expensive as
She
it
hangs
is.
out with the likes of Farood Hakim is the problem.
Yeah. Yeah, he's just a couple miles north of me. So this is an area where I don't see myself leaving. So I've set down roots here for sure.
That's
Marta,
fantastic.
so I need to ask you a little bit about your ortho training. So your traditional ortho training that you came out with, how
Mhm.
much did you know about aligner therapy? And I guess I'm sorry, where did you say you did your ortho training?
At Pacific.
Oh, you did your ortho
UOP.
training there as well.
All the
So
way.
yeah, so I don't know, maybe that is a more advanced program, but I do know that a lot of the ortho programs kind of lag a little bit behind where we are clinically in the outside world. At least that's been my observation. So how would you rate your preparedness for a real orthodontic practice when you got out? What were some of the shortcomings that you saw in your orthodontic training? And then where did you take it from there?
So I at the time that I was a resident, Dr. Bob Boyd was our chairman. So one of the first users, and everything that we learned in residency was sort of looking over his shoulder. He'd play with the clean check and say, "This is how I do it." We didn't really have a science about it, like a checklist. Really, we were just learning as we went. And since graduation, I really had to lean on the online webinars, all of the opportunities. I would commute. I had 10 hours of commuting in the first year that I graduated, all around the Bay Area. And I would just, you know, listen. I wasn't looking at my screen, but I would be listening to these online pre recordings and trying to just take up everything I could from speakers like Bill Codman and people who'd been doing it from the beginning. So I think right now the residents are very lucky at our university because I teach the clear aligner course. They get an hour with me every week. They do it in the clinic. Like maybe half of their patients are Invisalign patients now. And that's not every residency for sure. But
No.
no. And so as someone who graduated and had to just go out on my own, I had to lean on Align really to provide that education post graduation.
And do you think, as a partner company, that they have been walking that journey with you? Because I think, a lot of dentists get kind of squirrely about vendors and educational partners that they work with. They feel like they're constantly being sold something, and obviously
Like
they're
another
going to make,
scanner?
huh? Yeah,
Like a new
yeah,
scanner?
yeah, exactly, like a
Yeah.
new scanner. But Jeff and I think genuinely agree that we're much better clinicians because of the companies that we have partnered with,
Mhm.
because they know their products so well. And I do genuinely feel that the majority of the ones that we work with are always trying to better their clinicians. They actually want you to be better, not just with their product, but in general as clinicians and providers. Do you feel like Align's sort of been a partner for you in that journey?
Yeah, absolutely. And so in those early years where it was just a dinner study club or some event that was local. You'd go and listen to a speaker. Well, what they have available now, they host 2-day events for new grads or third-year residents, a whole 2-day course that they're not charging those people for. They're having those residents come in, get a full immersive experience, more education, more training. And really, we focus at those events on education, not on selling scanners. Like, truthfully, our PowerPoints are about how to do bicuspid extractions and how to do the mechanics and take care of our patients. So I think that the amount of content they have available for people it's pretty amazing, all the opportunities that are available.
And what percentage of the cases that you treat now would you say are aligner therapy with Invisalign?
So I transitioned from 50-50 to 80% Invisalign.
Yeah.
And now I'm at about 90. And now my TC has like a little cap of how many braces patients she's allowed to do every month because I've got my workflow so good and I have no problem doing clin checks that really, if you throw a braces patient in, there's something analog, it kind of messes up the flow. So yeah, I heavily Invisalign practice.
Yeah, it's really neat to hear that because that's something, I'm not an orthodontist, but I very early in my career learned orthodontics just because we only had one orthodontist in the entire county where I lived. And so I went off to Atlanta for like 5 years every month and learned how to do straight wire. And it's really been an interesting transition that where I used to do almost all straight wire at the beginning, I wasn't even allowed to submit a case to, Invisalign. And then I actually became one of the first GPs that was able to submit a case to Invisalign. And I really haven't looked back. It's really just been an ongoing transition where I say, well, I always used to say I couldn't do this with Invisalign, but I really can now. And I can do it just as efficiently, maybe even a little more efficiently without some of the common risks of orthodontics, like fighting hygiene problems and things like that.
Absolutely. To be able to say, when I was 50-50, I would say, well, you could do either or, you'll get the same result. But once I really saw through reflecting on my cases, wow, I'm finishing 4 to 6 months faster with the aligner patients. That's something that's meaningful to the patient, less office visits. I can say that in the consult with confidence. Hey, this is actually better. So yeah.
Love it.
So let's talk about the scanner because obviously we don't really have to talk necessarily about the new scanner because not a lot of people know much about it yet. But let's talk about scanning in general, especially with the iTero in your office.
I want to hear about it.
Huh? You want to hear about it?
I want to hear about it. A little bird says he would like to hear about the scanner.
Yeah. Well, I may have had the opportunity to use it. And it's really fast.
I want to go fast.
Yeah. Ricky Bobby, you can go fast too. I think it's going to be a really nice welcome addition to the iTero portfolio. And it definitely is going to meet a lot of needs in the scanning community. I think we're just at the tip of the iceberg of where the evolution of this dentistry and scanning is going. What I love about new scanners in general, and what I love where Align is constantly taking these scanners is that they're not just this fancy PBS machine anymore. The things that we're doing with it and how we're communicating with patients is so much bigger than just capturing data for data's sake. So I love that there's constant evolution in that. So we'll just leave it at that for now. But for you, because I'm genuinely curious, I'm a GP. So, for Jeff and I to do an iTero scan and a hygiene checker, for a patient, we're talking about that kind of stuff, right? We're talking about oral hygiene and recession, fraction attrition, and malocclusion, all those things. In their regular recare visits, that's a very normal part. I'd love to know what the iTero means for an orthodontist other than just a PVS machine, which obviously is vastly superior for taking intraoral impressions for sure. But just how you're using the technology outside of capturing just the data.
Yeah. So our new patient consultation starts with a scan. Facial photos. We're using the Invisalign Practice app, capturing the wide smile. They come into the consult, and I actually really enjoy the Align Oral Health Suite that they just upgraded us to, because I like how it's organized there for my TC with looking at tooth health, bringing in the lens. On the 5D Plus, you can bring over the little magnifying glass. You can show patients, oh, I noticed this, I noticed that. We're walking through. This is your existing dentition. We're doing it too, because some of the people haven't seen a dentist in a while.
Mm-hmm.
Like they came on as a referral from the internet, and I need to educate them on their entire health of their teeth rather than just focusing on the ortho. So we'll walk through, show them the gingiva. If I had upgraded to Neri, I could show them that too, which would be cool because again, I'm educating them. And then finally, I might show them their bite. So showing them their bite, kind of going through that, they say, okay, that's interesting. You know, it's on a big screen. The kids kind of laugh about it. Sometimes I let the kids play on the iTero just to move it around like a video game. But really, the Outcome Sim Pro, the simulation, that is so impactful in my consultations. So we run the Outcome Simulation Pro. If we took a wide smile, they can visualize their smile right there at that moment of the consult. So it really saves me time from maybe having to do a 2-step consultation like I used to, and where I would need to say, okay, I need to go do a workup, and they show you a couple different options. I can do it right there. I can use the original outcome simulator. I can show extractions, and just the amount of information I can get across visually is it makes my practice efficient, and visually people can understand what I'm trying to show them. And so our office gets complimented all the time on the amount of communication and understanding that patients get. And, you know, maybe it's a lengthy consult, but hey, they need to know. So from my standpoint, I've removed taking intraoral photographs. And that's why I'm so excited about this new scanner, because the resolution is that much more amazing.
It's so much better.
It's so beautiful. And yes, it's faster at scanning. My assistants are already pretty fast because they're doing 70 of them a day or whatever. But all of our progress records, all of our documentation, everything is just the scan. So the amount of time I'm saving now from intraoral photographs for every additional aligner or progress, even our braces patients, it's a huge time savings to stop doing that. So that's how we're utilizing it for just not just the capture of information to do a clin check, but patient education.
So you bring up an interesting, Jeff, I got to ask one quick question and then I'll totally be quiet. Are you scanning patients in bands and brackets? Because I'm curious, like, would I do that so I could actually see the things I'm not seeing? Because I do the same thing now for diagnostic workup or whatever. I scan because I know there's things I'm not seeing just intraorally looking. And you need those models that you're manipulating around and looking inside and outside. Are you doing the same thing?
Yeah. In dental school, you might take a impression and pour it up and look at marginal ridges and try to figure out how you would reposition a bracket. Well, at my progress appointments, which we take the pano progress scan, I'm zooming in and I can see marginal ridge discrepancies. I wouldn't have seen that, or I could have, but it's just that much more clear to see where I need to reposition a bracket. And then, hey, patient's sitting there, parents sitting right there, I can bring the magnifying glass over and say, we have some brushing issues. You know, it's just that much more obvious when you can zoom in and show them that level of detail. So yeah, I use it for the braces patients as well, for all their progress records. They can virtually remove the brackets, so I can order retainers. So the retainers are there the day of debond for those patients. Yeah.
Very cool.
So I think that's just such an important message, because I think some dentists are reluctant to get into scanning, although we've really seen that barrier come down in the last few years. But some dentists are reluctant to scanning. They're like, oh, I'm not milling any crowns and I don't really need that. I've done so well with my impression material. But I really think where the opportunities are for things like what you've just described, the show and tell that happened maybe half of the time before when we asked our hygienist to, use an intraoral camera. And, now to have this kind of opportunity to say, look, here it is in front of you. Here it is in great quality. And now, not only that, we're not having anybody pouring up models. We're not having to store a lot of models. We've got all of this digitally, and we can always come back and show a patient later on, maybe you don't remember where we were when we started, but look where we were. Look how look how look how the wear facets have grown. Look how these erosive lesions have grown. I just think there's so much opportunity beyond what most dentists think scanning is all about. And really, I didn't learn that until we put the iTero in the office.
Yeah. I mean, time lapse is really powerful.
Yeah.
To be able to show them where you were a year ago, where you are today, see changes, like you said, wear facets, recession, all those things. You said, remember when I said this would happen? And look, it happened.
I'm so smart. I like the I told you so is way better than the why didn't you tell me?
I wish I had $1 for every one of those.
Yeah, for sure. For sure. But just to elaborate on time lapse, because I don't know if everybody knows the term if you're not an iTero user, but that's where you can take a pre-scan or a scan at a point in time, then take a future scan, and then the data overlaps one another and it gives you measurements of change. And, GPs use it to talk about erosion, recession, abfraction, attrition, all those fun words, to be able to really actually measure change and then to help patients understand the activeness of those changes. So is this a historical representation of things that happened long ago, or is it an active problem that probably is going to require some intervention? And it does get a lot more buy-in from patients. At least that's been my experience with time lapse for sure, to be able to do that. And I think I just continue to be, my eyes continue to be incredibly open about, you're really limiting yourself when you just have a scanner to just make a crown or just take an intraoral impression, when you're not really taking advantage of all the things Jeff just talked about with the scanner and how impactful it is to have those conversations with patients to see. Do you use your scanning images, your progress? How do you communicate that with the GPs that you're working with? Are you exporting those things out to them to keep them in the loop?
So right now, you could either export the regular composite like we do for orthodontic photos. You can export it from your phone. So all the images are there. So in the app, you could just export it there and then put it to a Dropbox folder. My team goes into myotero.com. They download either screen captures, if I've done some screen captures, or just the whole set. They still get loaded into our practice management software. And then that gets sent in the report. So that's why I'm so excited about this new scanner, because the resolution is that much crisper. Where, yes, I know that if I hover my magnifying glass over, it's an actual image, but it was still like it's a constructed image when we look at that and we export into our practice management software. And sometimes it's not as crisp as a photograph, but what I've seen from the new one, I was just blown away.
Yeah.
Like, who's going to take a occlusal or, cheek retractor to their patient ever again?
Yeah.
Yeah.
I have to know, because I've seen quite a few orthodontists starting to dabble with other clear aligner companies, ones that are specifically advertising and marketing to orthodontists. But we certainly have the same thing going on in the GP world. Plenty of clear aligner companies wanting to compete for the business. Why Align for you? Why have you experienced other aligners? Do you have cases that you've sort of compared and contrast? You're in a teaching and educational environment. So what are you guys doing there to look at Align versus others?
So absolutely, the residents need to dabble with a little bit of everything. They can't just be taught one way. They can't just be taught braces or so on and so forth. When I first graduated, I did work as an associate in an office that used another aligner company, but those were early days. 2011, you had a ClinCheck versus something else, some other way of visualizing it. And was the doctor doing the setup, or was someone doing the setup for you? And all you saw was the before and the after. I think that what drew me to Align was how progressive it is. And there's just no way anyone can catch up with all of, not just the platform, but just the technology and science in designing the aligner, in designing the attachments. Not all attachments are equal. The optimized attachments, they work a different way, and no one else has that. or a platform to go along with it to make my life convenient. So I wouldn't stray even for some savings, because it would make my life more difficult.
For
And
sure.
I've predictable results. Trying something else that's an inferior product to save money would end up costing me more time in the long run. And I'm all about the time.
Mm-hmm.
Yeah.
Marta, that's a perfect segue, because I know one of the things that you like to talk about are biomechanics.
Mhm.
And so explain a little bit to everyone out there, because most GPs are not touching ortho. The ortho that they're touching is just very basic aligner therapy. So talk a little bit about how we can achieve some of the same biomechanics, and how in some cases it may even be superior to bonding and bracketing, especially when brackets maybe are not placed ideally, and so on and so forth.
So there were kind of two questions in there. So the last question was like aligners superior to brackets in those kinds of situations, and why I would recommend it.
Yes.
Yeah. So think about how an aligner works. So it wraps around the entire surface of the tooth. You've got contact on the lingual, incisal, facial. A bracket's only on the facial. And you can push and you can pull, but you're engaging at a slot, but there's really a kind of a contact point. So say a patient has a tongue habit or an open bite tendency, aligners would be far superior for those kinds of cases. You've got the plastic on the lingual. The force of the tongue can't negatively impact your treatment as much. So habits, number one, those open bite patients, I would steer them towards aligners. When it comes to class 2 teens, so you catch a teenager coming in and they're 14, and you need to get going on correcting their bite because you want to have growth remaining. With traditional brackets and wires, usually we bond the brackets, level and align, get to some heavy arch wires. Somewhere around month 9, we start elastics. That's just how the flow goes. You've lost 9 months of growth. With aligners, we start class 2 elastics on day 1. That's why their treatments are going shorter, but you're taking advantage of more growth remaining. So that would be another instance where, if they have a big class 2 and they're coming a little late, I'm going to get started with aligners as soon as possible.
And having gone into orthodontics as a GP, at the beginning, I was using a lot of functional appliances, which were kind of in vogue in the early 90s when I started doing this.
Yeah.
And the industry kind of pushed away from it, but I'm like, y'all are missing the boat here. We have an opportunity to take advantage of growth and reposition them now. No, I'm not trying to finish the case now, but I want to get whatever growth I can. And, if it means expanding the arch, if it means, putting them in a twin block at the time, or Herbst appliance or something to help facilitate the more normalized growth, which we realized at the time we realized after we were also improving the airway. We were improving tongue posture. We were doing so many things we didn't even know we were doing in functional appliance therapy. But it's nice that's almost incorporated now into the aligner therapy with the MA attachments that Align uses, and other new technologies that Align has come out with. They've made them as much into functional appliances as just traditional ortho appliances.
Absolutely. And there's always going to be that skepticism, but there's a paper in the AJODO Orthodontic Journal comparing MA to Herbst, and you look at the skeletal changes, they're there. It's effective and a great appliance to use, and it's just getting better and better, right? Someone complains about the wings. They're not going to just put something on the market and leave it the way it is. They're always working on improving that stuff behind the scenes so that we can really expand our portfolio of tools we can use. But
so this is probably one that's near and dear to Jeff's heart, but let's talk about early interceptive ortho. I've dabbled a little bit with that with clear aligners as well, and starting to see the power of getting them in earlier and earlier. And then how much better it makes secondary treatment. It's a lot easier. So let's talk a little bit about what an early interceptive ortho looks like in your practice. How young are
Yeah.
you treating? What do you think the major significant advantages and disadvantages are when you're starting to use clear aligners for youngsters?
Sure. That was another definite like line in the sand where there was a day where I said, this is the last time I'm putting braces on an 8-year-old or taking them off, right? Taking them off and hygiene issues or a little bit of decal on an 8-year-old just breaks your heart. So no, I do a lot of interceptive treatment with, and it's all aligners now. It's all Invisalign first. But one of the things that we had as a limitation for a while there was the fact that aligners don't put orthopedic level forces. They put dental level forces. And so if you wanted to expand the palate, you had to use something else first. And so that was one of those things that us as orthodontists have just been saying, please, we want to get out of bands. Here we've convinced them that aligners are the best, but we're sticking bands on for an expander. So that's been my protocol. Get that skeletal expansion first and then go into aligners. It's usually about a 6-month expansion phase and a 6-month aligner phase. They're done in 12 months. When I go back and I look at our little phase 1s with braces, the number of office visits was double, right? They were in there every 4 weeks because a wire was sticking out, a little spring or some comfort sort of thing. And the treatments all took at least 6 months longer. So it's made it where I wouldn't say I'm over treating, but I think that once other parents heard about how convenient and comfortable this is, it's like the number of phase 1 starts boosted. They all talk about it. And still pick and choose cases based off of my original principles where I would or wouldn't treat this. But it's definitely one of those things that draws people in. Parents are talking about it.
You do a fair amount, don't you, Jeff? Or
I
when
do.
you were, yeah.
Yeah. And, for at least as long, I've sold one of my general practices, but still have the other. But as long as I have general practices and, the parents, they ask about the kids. My practice that I sold, out of the first 10 years I was in practice, the largest demographic within my practice was the 0 to 10 population, because we also did not have a pediatric dentist, but just one for the entire county when I moved here. So it was really enlightening. And a lot of what I learned, was, of course, just watching what happened to the kids that I was able to get in and do phase 1, and then watching what happened to the kids where I wasn't able to get in and do something. And that was a seller. And I actually have a few grandkids at this point. I know I don't look that old. Oh, come on.
Oh,
We don't have
yeah.
to say it. But it's amazing because once the word gets around that you're really just trying to improve skeletons, improve breathing, improve function, and the best time to do that is while they're growing, not when they're at the edge of that growth spurt.
Yeah, absolutely. And then treatment time, phase 2 is shorter if they need
for
it.
sure.
If they need it, it's some little bit of crowding, misalignment, that kind of thing.
So I'm sure some people are wondering, okay, well, how about compliance with an 8-year-old and clear aligners? And how is that looking in your practice? What are some of the motivators to keep them on track? Because, teenagers are definitely not bought into orthodontics, but at least they're sometimes motivated because there's an aesthetic outcome that they're kind of hoping for. But 8-year-olds probably are not quite in that same motivation pathway. So what does compliance look like for the young ones?
Surprisingly, they are the best. And they can get away with a little bit of less wear time.
Yeah.
They could probably get away with 16 hours a day, but they are good little rule followers. For the most part, the ones that I have trouble with are people who like to fidget. Fidget with their aligners. They play with it. It cracks. They have to go to the next one. That has been the issue. Not that they're not wearing it.
Yeah.
Just that they're sort of playing with it. And those people, we add some more retention attachments and those kinds of things. We try to work through and get them to fidget with something else. But boy, that age group of 8 to 9.5, they really wear their aligners. And I almost never do a refinement on those patients. They pretty much finish one course of aligners and they're done.
As anecdotal evidence, I treated both my daughters. They did awesome in phase 1. Then I treated my middle daughter in phase 2, and she's been awful.
Yeah.
Like, really terrible. So I'm really glad I did phase 1
You
now,
bad boys.
because phase 2 is not going great. And so
Yeah.
the teenage laziness and the, whatever is definitely kicking in, where
Mhm.
she was much better at rule following at 9 than she is at 12. So
Yeah.
I can definitely just give you a very limited example of that living out in my very daily life, and being
Yeah.
quite a bone of contention between me and my daughter. So anyway, so what's next for you? Where can folks find you? What does future look like for you in the world of orthodontics and with Align?
So I am looking forward to my mix that I have of private practice, teaching at the dental school, and going to Align events. I have a list of webinars that I'll be hosting and events in Raleigh. And yeah, if anybody wants to reach out to me, I'm sure we can share my email if anybody had any questions. But it's just continuing on with my little 9 and 5-year-old. They keep me busy. There's nothing you can really see past that too far.
No, I know, right?
When they're young. Yeah.
So for folks who are thinking about teaching at
Mhm.
the local dental schools that they happen to be in proximity
Yeah.
to, or have a passion for that, how did you get started with teaching at the dental school? And then, what does that look like for you alongside of your private practice journey?
So it is it is an honor to teach. In a way, you are with these bright minds that are trusting you, and you need to stay on top of everything that's current and new and coming out. They are going to ask, and you want to give them the best information you've got. So I started teaching literally a month after I was 5 years post graduation. My chairwoman called me. She said, "Marta, you said during the interview that you would come back and teach. It's been 5 years. It's time." So at the time I said, "Well, I'm not that busy. I can come in and do that." My kids were young. I started doing a day a week, and it just became one of those things where, because I built it into my life, we're not paid for these things, right? Like, we're paid for parking. And here is a day a
Right.
week,
A
right? Think about
day.
the potential.
Yeah.
But it's the long game. It's honestly the amount you get from it, the engagement you get with these young people who are so excited about the profession, the opportunity to push myself to stay on top of everything that's out. Because I've been doing it for so long, I can't imagine trying to go back now when I'm at the busiest time, when my kids are this age and everything. Could I give up a day a week if I wasn't already doing it? I don't know, but
Mhm.
I'm glad I've done it, and I don't see myself not. So
I
if
love
you're,
something that you said, because I've always felt this way, and I've always said this, that teaching makes you have to understand, and it
Mhm.
makes you have to learn. You better know what you're talking about. You better be able to back up what it is that you're saying when you're standing in front of a group of smart people that can very easily find out if you're just throwing a lot of anecdotal stuff at them, or if what you're saying really has merit. So I love that you said that, because that's been one of the things that I've loved about teaching, is it's made me stay on top of all of the topics that I like to talk about. And we can't be everything to everyone, but certainly the things we're passionate about, it's easy to kind of fall behind a little bit when we just get into our offices and our own little world. But when we have to stand in front of our peers, it's a whole different story, isn't it?
yeah, and that's what got me to be so good at doing ClinChecks, was the fact that I spent that time looking at my additional aligner scans, looking at what I did. What can I learn from this? How can I turn this into a teaching moment when something happened I didn't expect? And then I can go off to school and show them. So that, yeah, build it into your lifestyle.
Yeah, exactly.
That never happens.
No, his cases are perfect.
Mhm.
Yeah, I feel
Errors? Computer problems? Never.
I don't know anything about that.
I don't know
Nothing at
anything about
all.
that.
Nothing at all. Let's talk, just as we kind of wrap up here, the collaborative relationships between GPs and orthodontists. And what's the technology helping us to do now is, we all share these mutual patients together. We're all wanting to be a part of their shared care and getting them healthy. What's the technology? What's the technology doing to make that relationship better?
So that's my 2024 focus, is getting at least my local general practitioners really comfortable with Smile Architect.
Yes.
And getting patients excited using all the latest visualization, showing them what their teeth could look like, and then collaborating. Right now we're doing it via Zoom, or I create a video. This is what your patient could look like. But if we could streamline that, where, they took a scan, do they need to come to my office and take another scan? Can we collaborate somehow where I do a setup and you show the patient? And sometimes patients don't even make it to my office, right? To be quite honest, they don't want to go to the trouble of going to another location, setting up an appointment. So I'm looking for opportunities to help facilitate using Smile Architect and really showing patients the opportunity for ortho and how it can improve. It can improve their plan, reduce the amount of tooth structure removed.
Yeah, I think that's a fantastic objective for you for 24. And I think many of us GPs and orthodontists could be working together better on Smile Architect in general. And really, GPs, if you're not using it and trying to do clear aligner cases and set up where you think teeth should go, you're really missing out on a huge opportunity to, as you noted, put teeth where they can go to do the least amount of invasive dentistry. And I hated the whole ping pong back and forth. Like, could you take a perio probe and measure this lateral for me and let me know if I need to move it over 1 millimeter or 2? And I'm like, okay. But again, it's a round arch and I'll try to give you my best guess but I got to get all the plaque off of it, to your point. And there's bands and brackets sitting everywhere. So we're trying to, it just can be so much more predictable and easy for the patient and for both providers on either side, not ping-ponging these patients back and forth, measuring a little bit over here and a little bit over there.
Yeah.
All right, Marta, so you have to do this for me one day. While you are at the school, I need you to seek out Farood Hakim, find out wherever he is, just open the door, peek in, and just say, "Very nice," and then just walk away.
And then just leave.
And just leave.
Actually, maybe run.
I guarantee he knows where it came from.
I will do that.
Just stick your head in, say it, and get out.
Can you record that, please?
What a pleasure having you. Thank you
very
so
much.
I know it's really obvious your passion for orthodontics and just wanting to do an amazing job and wanting to share that with everyone else out there. So we appreciate it. I know your patients appreciate you, and I know your referring dentists appreciate you, and certainly everybody that's learning from you. So
Thank you.
we really do. We really do think it's just an amazing thing when people like you come on and spend some time with us.
My pleasure. I enjoyed myself. Thank you, guys.
Hey, we didn't do so bad, Jeff.
No, I was able to get my face up.
Yeah. And your voice. All the things.
All those things.
Yeah,
I think I got it worked out now. Okay, Marta. It was great seeing you. Have a great evening. Thanks again for being with us. Get home to those babies.
Thank you.
Well, JB?
Yeah.
We did it.
By
it was
the
a little
skin of our
stressful
teeth
at the beginning. I have to admit, Chad not feeling well. And then I was like, okay, we got this. It's, not a big thing. And then, no, sir. No soup for you.
No. It never fails.
Well,
this is live. This is what going live means. It means a shit show every time.
That's right. But you know what? It always works out.
We're charming.
Exactly. This is us. Anyway, JB, thanks for carrying all of the weight pre-show. I know you have a big trip coming up to Aruba with Clinician's Choice, and I hope you have a great time. Hope you learn a lot. Please say hello to everyone for me.
Will do.
Want to thank Align for being an educational sponsor and being a big part of what we do here at Dentists in the Know. Want to thank all of our educational sponsors for that matter. A lot of big stuff coming up. We've got Aruba with the American Independent Dental Alliance. Aruba.
Mexico.
JV's got Aruba.
Yeah,
we
Mexico.
have Cancun, Mexico with the American Independent Dental Alliance, and that's coming up the weekend of the 15th. And then the following week is Chicago Midwinter. We will be on the floor, ladies and gentlemen, so please come by and see us. We'll have a booth. We'll have some goodies for giveaway. We're going to be doing some live interviews on the floor, and just really looking forward to hanging out with everybody who has supported us over the years. So with that, JB, good night. All of you, have a great evening.
Have a great night, everybody.
See ya.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.